Thank you very much, Chris. And I'd first like to start by thanking Sir Munir for inviting me. It's been a good morning, and I hope to add to this. Just following on from what Chris said about cancer, in my field, in respiratory medicine, we've been kind of chasing cancer. It's been a shining example of how one should do things. And so really, I guess the first question that may be on your mind, why is stratification at all relevant for a disease like asthma? You probably all know somebody with asthma. Well, they wheeze, they get a bit of steroids, they exacerbate every so often. So why? Well, the answer is, this is why. So if you know a little bit about the pathobiology of asthma, you'll know that it's associated, or people think it's associated with something called eosinophilia. Eosinophil counts are raised in asthma in a significant proportion of individuals. And indeed, if you go across the spectrum from control individuals in green, the turquoise intermittent, very mild forms of asthma, mild, moderate, and severe, you see this escalator effect. So this is looking at sputum eosinophils, those bright sort of pink cells on that slide. And that is true. Asthma does get more eosinophilic as it becomes more severe. But what you have to observe there, this is a log scale, and you see the enormous heterogeneity within each category. So if I draw your attention to this individual here and to that individual at the extreme ends of the spectrum, you've got to realize that these are different diseases. Now, they both tend to be, they both happen to be on similar treatments, including oral steroids. So this individual, the eosinophilia has clearly been switched off. But in this individual, the eosinophilia, despite being on 40 milligrams of supervised prednisolone administration on a daily basis, they were highly eosinophilic. That is terribly relevant. That's ever since I set my eyes on this data set, I realized that if we're going to make progress, we need to begin thinking seriously about stratification. So, come to definitions. So, in my field, this body called the GINA, Global Initiative for Asthma, it's an international body which defines this condition. This is as good as it gets. Isn't that awful? I mean, it's a terribly primitive definition of a very complex disease. And this despite, millions of pounds, dollars, euros, whatever currencies being invested into studying the mechanisms of asthma. And we know so much about the mechanism, but nobody's bothered to, or nobody's been able to use that to stratify disease. And this is as good as it gets in terms of airways inflammation. The statement is that asthma is usually associated with twitchiness of the airways, hyperresponsiveness, but these are not necessarily or sufficient to make the diagnosis. So obviously you sense a bit of frustration in me. So the first time that the word phenotype appears, so phenotyping is the key to stratification, it appeared in 2017, and it says recognizable clusters. Okay. So at least we got to look into as a possibility that this is a stratifiable disease. But it finishes with the following statement, that no strong relationship has been found between the pathological features and clinical patterns or treatment responses. And that is clearly the key challenge. And I'll talk you through how I think we should be going about it and how we have, to an extent, already been going about it. And this is where we are at the moment. This is a very simplified recognition of asthma phenotype. So you've got the umbrella term of asthma. Some people develop asthma when they're young, so children typically, and others develop late in their life, so 40s and onwards. And we can characterize these by symptoms, by how often they exacerbate, by their lung function. And then there are, broadly speaking, two emerging umbrella mechanistic phenotypes. One referred to as type 2 inflammation, which is, evidence shows, driven by type 2 cytokines So interleukin 4, 5, and 13, which drive processes for which we find a lot of evidence in asthma. And that's a large proportion of asthmatics. About 60% of asthmatics fit that category. But then there are those in whom we look for patterns, and we do not see any evidence of, or very little evidence of, type 2 inflammation. And that is a bit of a black box. It's still something that we are puzzled by. Now, the aim over the next few years is to further substratify these. Why? Well, this is why. Because we're now entering an era of biological agents. We're way behind the rheumatologists, way behind the gastroenterologists. But we do have some candidate targets. So here's your type 2 cytokine, interleukin 5, 13, and 4. And this is a non-T2 cytokine, interleukin 17. And there are a number of drugs. I'm not going to go through these in the interest of time. But you see that the timelines are very close. So let's say that all of these drugs make it to the market. What's the first question you're going to ask? Well, how will I know which drug to give to which patient? How will I know, will I be able to predict? Or do I have to wait a whole year to find out if it's had any impact on them? What does that do to our NHS budget? Clearly, not something that we can allow ourselves the luxury of just being complacent. Okay, so I'm going to take one example just to show you how critical, and by critical I mean all in uppercase, critical it has been to stratify patients. This is an anti-interleukin 5 antibody that was developed by a consortium of companies previously, and then merged subsequently into what we know now as GSK. And what the objective was to target this type 2 cytokine. Why? Because it is a key cytokine that drives the maturation of eosinophils. And remember, asthma is an eosinophilic disease. And in doing so, the idea was to remove the eosinophils, return the inflammation down to as low as possible, and thereby improve control of asthma. And what did they do? They took all of severe asthma. Anybody who came along, they recruited them. And 2 clinical trials costing millions of pounds were negative. Again, why? Because of this. We don't know. They didn't even look at, they didn't even characterize the patients by their eosinophilic profile. But so they may have just by chance stumbled on individuals who have no eosinophils. So what are you targeting with an expensive monoclonal antibody if the target isn't there? So then, thanks to Ian Pavord, who was at the time in Leicester, he's now at Oxford, he really, tucked a bit between his teeth, and he raised money himself. He just got the monoclonal antibody and did the trial himself, and selected individuals with sputum eosinophil counts that were raised. And at the same time, a group in Canada did the same with this antibody. They somehow got hold of the same antibody. And what you see here is that this antibody, as predicted, is very effective at really depleting the airways of sputum. It also depletes the circulating eosinophil counts. In other words, the pool of eosinophils that end up eventually in the airways. And as a consequence, when they looked at exacerbations, so this is the annualized exacerbation rate, this is individual exacerbation rate, you see that the mepolizumab was hugely effective. There was a reduction of about 70% in that trial and 60% in that trial of exacerbations of asthma. Bingo. That was the proof that stratifying, selecting, pre-selecting, enriching the population of patients, the drug was effective. And that opened the door. And as you know, pharma behaves a little bit like a pack of kids. When the first kid, runs after the ball, everybody runs after the ball. And so and this was terribly enthusiastic or enthusing for the companies, because they saw that there is something to be done. Okay, so the next question, you'll say, okay, stratification requires tools to stratify. So yes, we heard from John Saville, for mental disease you can stratify by anxiety, depression, and so on. But in an inflammatory disease, it makes sense to use a biomarker. And so the question that you might be asking yourself, well, are there any biomarkers? Well, there are, not many, but there are some good ones. Okay, so eosinophilia, as you've seen, is a good biomarker. It's a risk of exacerbation. We know that people with eosinophilic inflammation are likely to exacerbate. Those are the ones who are likely to respond to steroids. You may not have known this, but not everybody responds to steroids. Not all asthmatics will respond to steroids. Even some mild forms of asthma will not respond to steroids. And why? Because they have neutrophilic inflammation. So neutrophilia is usually indicative of more severe disease and lack of response to steroids. Before we looked at this, we didn't know. We thought that everybody should respond to steroids. And then there's this very nice and very simple and inexpensive way of looking at an overall inflammatory response of the type 2 profile, and that's exhale nitric oxide. Our epithelium produces nitric oxide, which is in very low concentrations, parts per billion, but you can monitor exhale nitric oxide, and it allows you to safely reduce the dose of inhaled steroids, thereby saving money and saving side effects from local excessive deposition of steroid. But another thing which we've now recently found through an MRC collaboration that John referred to this morning, we can test whether a patient is adherent to treatment by looking at whether they suppress their exhale nitric oxide. What is the relevance of these biomarkers to responses to biologics? This is the key sort of use, or the key requirement for good biomarkers. Well, as I showed you, eosinophilic inflammation was predictive for anti-IL-5 treatment. It's also predictive of anti-IG monoclonal antibody. And this is the latest drug, dupilumab, which is an anti-IL-4 receptor antibody, which knocks out interleukin 4 and interleukin 13. So really a double whammy. There again, eosinophilia predicts the clinical response, a reduction in exacerbations, improvement in lung function, and reduction in symptoms. And exhale nitric oxide is also predictive but complementary to eosinophilia, and so far it's been shown to be a good predictor of response to anti-IG antibody as well as to anti-IL-4 receptor antibody. But we now live in an era of omics, right? Beginning with the genome, but going through the transcriptome, proteome, and metabolome, and technology is just fantastic. Every day we find out about a new widget, a new tool, and this is what I want to share with you, because I think this is part of our future. So. I can't talk about this without mentioning this fantastic consortium, which I had the pleasure of co-founding with a Dutch colleague, Peter Sturck, and 2 colleagues from Imperial College Fantrum, and Ian Adcock, and another 20 academic centers, 11 pharmaceutical companies, patient organizations, and charities. It was really a partnership, a fantastic partnership. And we couldn't do this in the UK alone. Why? Because this cost 27 million. I'm not aware of a 27 million grant being given by any funding body in the UK. So this was an IMI initiative, and I'm heartened to hear from John Saville that it looks likely that we will remain associated with European funding streams. So this is what we did. We created a large cohort, 1,000 strong, amongst which 400 children with asthma. we took samples, essentially any sample that you can think of, we took it. From biopsies, bronchial biopsies, exhale breath, urine, blood, and so on. And we applied these omics technologies. We had a fantastic platform. And if there's one thing that you might want to take away from my talk, remember Transmart and Etrix. Look it up on the internet. It's a fantastic data management, knowledge management tool, which is sort of like a federated database handling tool, without which you cannot handle large data. And the idea was to produce fingerprints of individual omics methods. So we wanted fingerprints or signatures, call them whatever you want, that define phenotypes of asthma using a single omics method. And then when you put the different omics methods together, what you get, collection of fingerprints, you get a handprint. And the idea is to have, and I think we're finalizing the analysis. It's extremely complex. There's probably going to be about between 8 and 10 handprints of asthma. In other words, 10 multidimensional phenotypes. So I'm going to talk you through two things. The first thing will be to show you clusters, in other words, phenotypes of asthma that are based solely on the protein signature in the epithelial lining fluid, which we recover by sputum induction. We get patients to inhale hypertonic saline, they cough up, and then we separate the cells from the fluid, and these liquids, these fluids are then analyzed by mass spec methods. So you detect in an unbiased manner about 1,500 proteins can be detected. And then you'll wonder, well, I don't know if you've ever seen a slide that looks like this, but this is what the tool that we applied to cluster here is something called topological data analysis. It's a fantastic tool developed by colleagues at Stanford University, and then they spun out a small company called IASD. And essentially what you're seeing here is 10 clusters, so 10 phenotypes defined solely by their protein content in their airways. And when we look for some additional features of these phenotypes, broadly speaking, 3 things come out which might resonate with you. So these 3 are eosinophilic, highly eosinophilic relative to the rest. These 3 are neutrophilic, and these 2, 5 and 6, they do not have many granulocytes in their airways. So that's something we call paucigranulocytic, but they are highly atopic. And I'll just spend a couple of minutes just to explain to you what this is all telling us. So in this case, a color denotes intensity. So blue means low readout, and red means high readout. So across that same network, what we have done is you can superimpose onto your proteomic clusters, you can superimpose eosinophils, periostin, interleukin 13, and atopy. And follow my cursor, please. So you can see that, as I said initially, these 3 clusters are red. They're hot for eosinophil counts. So this is, good going eosinophilic asthma, but the rest isn't eosinophilic. These are neutrophilic forms of asthma here, and these are paucigranulocytic. Periostin is a biomarker, a circulating biomarker that Roche is developing, and it is a type 2 biomarker. And you can see that wherever you got eosinophilia, you got raised levels of periostin. So we have a good circulating, simple biomarker that we can use in the clinic. Circulating interleukin 13 is also co-localizes with eosinophilia. And then the next question, so some of you might think, well, asthma is an allergic disease. Yes, in kids it is. And the question is, okay, so how is this driven by atopy? Atopy is defined by skin tests, and if you come up with a single, at least one skin test positive, then you're defined as being atopic. And so let's see how these individuals look in terms of atopy. Well, we expected that the eosinophilic ones would be highly atopic, but they're not. Just over half of them are atopic in this cluster 1 and 2. And this cluster is highly atopic. But what's interesting is that the neutrophilic clusters are highly atopic. And you would never have found that out if you didn't apply this kind of open, unbiased approach to how you scrutinize your data. Moving on, what we then did was we took the sputum cells and extracted the RNA and did whole genome array analysis. And this is a simplified depiction of what we saw. So here you got 3 neutrophilic, here you got eosinophilic, and then the highly atopic post-granulocytic. And if you look at, it's too much to dwell on each individual data set, but broadly speaking, the neutrophilic forms were quite different in terms of the gene expression profile from the eosinophilic. The eosinophilic had raised levels of interleukin-4 and interleukin-13, whilst the neutrophilic forms had switched off their interleukin-13 and interleukin-4, but were instead going down a Th1 pathway. Now, this is critical for understanding disease and understanding how you position your drugs, how you select patients for treatment. This is, again, too busy I could spend half an hour just talking about the individual readouts here. But what I wanted to show you here is when you look at the network, what we see, and this is the beauty of topology, which is essentially the shape of data. As you go from the post-granulocytic towards the neutrophilic and highly eosinophilic, disease becomes more severe. There's more expression of pro-inflammatory, pro-remodeling genes, and the disease becomes more severe. It is more Th2 at this end. As you go towards the right, it becomes more Th1. So this is a completely new way of looking at asthma, something that we couldn't do previously. Okay, now I'll move on to something very opposite to eosinophilia. And this is this chap here, interleukin-17. So interleukin-17 is something that has been of interest to many people, but not to many of us in the field of asthma. It has been shown to be something that is correlated with severity in patients with COPD. But then we thought COPD and asthma are, two different diseases. So who cares about interleukin-17? So just very briefly, interleukin-17 is derived mainly from these cells, so T cells, and gamma delta T cells, INK T cells, and ILC T cells. In mouse studies, there is some overlap between Th17 and Th2, but in humans we believe that there is very little, if any, overlap. Now, where does T17 asthma fit? This is a conceptual slide where Chris Breitling and colleagues from Leicester, kind of reflected on where T17 might fit, and they grouped it with neutrophilia. But there really was very little evidence of this type of inflammation. So what we did was we took the bronchial brushings and did standard hierarchical clustering. And so this is, just to explain briefly, you take a signature that is typical, that is characteristic of a type 2 driven response. These 3 genes are activated in the epithelium by type 2 cytokines. And similarly, if you put interleukin-17 onto the epithelium, you get these 5 genes that get upregulated. And you see that patients with asthma, broadly speaking at the 2 extreme ends, can be characterized as being either T2 high or T17 high. And they're mutually exclusive. So busy slide, so please follow my cursor. This is just to compare the clinical characteristics and to show you how this new way of unbiased looking at data tells you something that you would have never, ever thought about before. Okay, so T17 high in this column, T2 high in that column. atopy, I'll be honest with you, I thought that these patients with T17 high would not be atopic. But look, 90% of them are atopic. They are, I also thought that they might be overweight, but they're not. They have a history of smoking in the past. Maybe that's what induces a switch towards interleukin-17. They have nasal polyps, a lot of them. Almost half of them had nasal polyp surgery. And they are on regular antibiotics. More than a quarter of them are on regular antibiotics. And not surprisingly, when you look at the microbiome, so this is the Shannon Diversity Index, what you have is a reduced diversity in the microbiome, possibly as a consequence of the regular antibiotic use, but also because of interleukin-17 itself. So, are there any simple biomarkers? Yes. These individuals with T17 high, they tend to be neutrophilic. They have neutrophilic inflammation in the lumen as well as in the tissue. They have more CD4 cells, CD3 cells. They have fewer mast cells detectable. Why? Because the mast cells are degranulated. And when you compare that T17 high, when you compare the whole genome expression, you see some very interesting differences that characterize this particular cluster. You see upregulation of chemokines, beta-defensin, S100. This is a neutrophil biomarker. Then you see a reduction in the expression of the tight junctions, which makes the epithelium fragile, which makes it vulnerable, because if you haven't got a good barrier, then stimuli will, including allergens, will drive your disease. There's evidence of systemic inflammation. There's upregulation of this molecule ICAM1, which is the receptor for viruses. So isn't this beautiful? I mean, this is telling you about completely new ways of explaining the disease. But this is something that should excite the speaker after me. There's overlap with psoriasis. We would have never, ever thought of that. Why do I say this? So this is from studies comparing biopsies, the gene expression in psoriasis lesions versus non-lesions. So everything that's red is upregulated in psoriatic lesions. And you see that in our Th17 cluster, you see that all this red. So about 170 of our differentially expressed genes in the T17 phenotype were seen in the psoriatic lesions. Importantly, when we looked at what genes are switched off by this antibody, brodalumab, which is an anti-IL-17 antibody, which has made a huge difference to patients with psoriasis, you see that all of these genes can be switched off. All of these genes can be switched off by anti-interleukin-17 treatment. So my hypothesis based on this, something that I could never have dreamt of, is that maybe we have a psoriasis form or psoriatic form of airways disease. Isn't that fantastic? And that is simply because you begin to stratify. Okay, so just to finish in a couple of minutes, Chris, of course, you'll be sitting there and thinking to yourself, well, oh, that's fine, who's going to bronchoscope every patient? We're not going to do that. So we need some simple biomarkers. I'm not a crazy academic. I realize that for clinical trials, well, maybe I am, but not so crazy. So we need something for clinical trials so that companies can select patients to treat them effectively. And indeed, we, because I'm a practitioner as well, we need something in routine practice. So what's easier than to pee? Pee in the pot, yeah? Now, what we have is an array of 11 eicosanoids, so derivatives of arachidonic acid, which is secreted which are excreted from the lungs, collected into and concentrated in the urine. And some of you might find things interesting, like LT4 is a sign of eosinophilic inflammation. But we were particularly interested in these two fellows here, because they're metabolites of prostaglandin D2. Prostaglandin D2 is an attractant for type 2 lymphocytes, so CCR4 is its receptor. And when we looked at our UBIPRED cohort, severe asthma was characterized by raised levels of this prostaglandin D2 metabolite. But again, I draw your attention to the enormous heterogeneity that exists if you do not stratify. So clearly what you're interested in is this bunch of people who are different from mild asthma and from control individuals. And this is why we're using this approach in a study where we're testing the mechanisms of the anti-IgE antibody in asthma. And very quickly, what's even easier is to just breathe out. And now you know that dogs can diagnose all sorts of things. In urine, they can sniff out cancers. They can, the eNose is a very sophisticated electronic collection of electronic sensors that sense volatile organic compounds. They don't give them an identity, but they just give a signature. And colleagues in Holland have developed this as an online system. So patient breathes, and you can see a child can do it. Patient breathes out, that goes into a cloud, and the result comes back. And this is the type of result that comes back. So does it differentiate? Can you sniff out an asthmatic from a person with chronic obstructive lung disease, COPD? Yes, you can. Look at the, asthma versus controls, I beg your pardon. So you can sniff out asthmatics very easily. The ROC curve is really very impressive, 0.9. That's really, really high. Can you differentiate between asthma and COPD? Yes, you can, to a large extent, but we know that there's an overlap, that some people with asthma have features of COPD. So that's why the distinction is not quite so clear, but still, the ROC curve is quite impressive. What about prediction of whether a patient is going to respond to steroids? So these are some of the biomarkers that are good at predicting, but look at eNose. It's much better at predicting whether a patient will respond or not. And here is the icing on the cake. Can it predict a response to a biologic? Yes, it can. Look at the ROC, 0.85. It can predict, sniff out who is going to respond to this expensive biologic. Okay, so this is where we are at the moment. We've got first of all, the clinical assessment of our patients, but what we are now entering in is a disease specification and a disease stratification. Without that, we're not going to make any progress. So what I hope is that come 2028, I'll tell you why 2028, we'll be able to redefine asthma, and we'll say it's a chronic inflammatory disease that consists of so many phenotypes. Okay? And then we'll be able to say which cells play a role in which phenotype, and then critically we'll be able to predict which patient responds to steroids, which patient becomes irreversible, and critically the very expensive drugs we'll be able to predict. Why 2028? Well, because in March 1988, I started a program with Stephen Holgate and Peter Houth in Southampton, and this coincided with colleagues at Imperial College. We decided we were going to start to phenotype airways disease. So we started a bronchoscopy program in 1988, and that will be 40 years from then, and I hope by then we will have clinched it. Thank you very much.